Good evening, and welcome to our third orthopedic lecture. This evening's lecture, titled In Good Stride, Anterior Approach to Hip Replacement, will be presented by Akash Shah, MD. Dr. Akash Shah is a fellowship-trained orthopedic surgeon specializing in hip and knee reconstruction. Dr. Shah graduated summa cum laude with a Bachelor of Arts in Biochemistry and Molecular Biology from Boston University. He was granted early acceptance into medical school and completed his medical degree and orthopedic surgery residency at Boston University Medical Center. After his training, Dr. Shah returned to his home state of New York and completed an additional year of fellowship subspecialty training in hip and knee reconstruction at the Insall Scott Kelly Institute at NYU, Langone Orthopedic Hospital in Manhattan. That's a mouthful. As an orthopedic surgeon with Arrowhead Orthopedics, Dr. Shah specializes in primary and revision hip and knee replacement, partial knee replacement, and urgent procedures for hip and knee fractures. He is interested in minimally invasive techniques, rapid recovery protocols, computer-navigated surgery, and robotic surgery. One of the procedures that Dr. Shah performs is the anterior approach total hip replacement that you will hear more about this evening. Dr. Shah's highest priority is for his patients to feel comfortable putting their utmost trust in him and to tailor a treatment plan based on their needs. He enjoys spending time with his fiancée Yogini, playing tennis, golfing, bike riding, running, and traveling in his free time. As a reminder, please use the chat box for questions, and we will address them as time allows at the end of the lecture. Welcome, Dr. Akash Shah.
Good evening, everyone. I'll be discussing the direct anterior approach to total hip replacement and why it's the most powerful tool for patients and surgeons in 2022. As a brief outline, I'll be going over the direct anterior approach, outcomes and expected recovery of the direct anterior approach, and the learning curve for new surgeons. In 2018, the American Academy of Hip and Knee Surgeons were polled as to which approach they used for hip replacements. 56% of all respondents reported that they used the direct anterior approach. Members not adopting the anterior approach said it was due to their perceived worse outcomes, having shown no clinical benefit and the steep learning curve required to master the technique. On the other hand, members who performed the anterior approach said they only used the posterior approach for select cases, such as revisions, complex anatomy, and body habitus. I'll be going over most of this throughout the talk, but as a bullet point, I'd like to highlight a couple things. One, the benefits of the direct anterior approach is that it's an intermuscular interval approach, meaning we go around the muscle, not through it, which means there's less surgical trauma. There's also a shorter hospital stay, typically for patients, a rapid earlier functional recovery, and a manageable learning curve, as I'll touch on towards the end. So let's start with the surgical technique. For all these next images, the head of the patient is towards the left and the foot is towards the right. The patient is placed supine on a radiolucent OR table or a traction table. If a traction table is used, it's important to check that the boots are locked in place and all traction is off. The patient is prepped out as shown above with the anterior superior iliac spine, the black arrow, and the tip of the greater trochanter, the white arrow, palpable. The incisions marked out based on the Smith-Pearson approach. The incision is approximately 7 to 10 centimeters in length, starting a finger breadth lateral and inferior to the ASIS and extending towards the fibular head. Next, after the skin is incised, the TFL fascia is identified. It's important to clear soft tissue where the fascia will be incised, as this will aid in closure later on. The fascia is then sharply incised with the medial portion carefully peeled off the muscle. A blunt cobra retractor is placed above the superior femoral neck. A cerebellar retractor or Morse retractors are placed distally, separating the gluteus medius, lateral, and rectus femoris, medial. This exposes the ascending branch of the lateral femoral circumflex artery, as depicted by the white arrow. Care should be taken to cauterize this vessel and its concomitant veins, as significant bleeding will be encountered if this is not done. After this, the deep fascia is incised, which overlies the precapsular fat. Once the capsule is exposed, a second cobra retractor is placed below the inferior femoral neck, and the cerebellar is moved to the middle of the wound. A capsulotomy or capsulectomy is then carried out. Studies have shown no difference in infection or instability rates between the two. Not pictured, the C-arm is brought in to measure the neck cut. For large heads or lots of osteophytes, a napkin ring cut may need to be performed. A corkscrew is then placed into the center of the head, and the head is then pulled out, making sure not to damage the surrounding muscle. If there's concern about damaging the muscle, a technique out of China proposes the anterior capsule can be flipped over the TFL and sutured to the skin to protect the muscle. This is useful prior to removing the head and reaming the acetabulum. So if you look at the diagram in the center, labeled B, the structure also labeled B is the anterior capsule. And what they've done is they've cut it in half, and they've actually reflected it over the muscle and tied it to the skin. This way, the instrumentation and the bone cuts can be made with minimal damage to the surrounding soft tissue. Once the femoral head and neck are removed, gross traction is placed on the operative limb to help with visualization of the socket. The labrum is then excised, the bony anatomy of the socket is assessed, and acetabular reaming is performed under fluoroscopy or X-ray. The cup is then placed. To determine the cup position, several tools can be utilized, including intraoperative navigation, computer software based on C-arm imaging, or C-arm techniques. Cup anteversion can be more difficult to quantify than inclination and plays a significant role in preventing dislocation in patients with spine pathology. This technique, published by Dr. Botner out of the Hospital for Special Surgery in New York, correlates C-arm rotation with cup anteversion. First, an AP pelvis X-ray is obtained, which matches the standing preoperative X-ray. The C-arm is then pushed in towards the operative side to help to obtain an AP hip. An assistant can measure the inclination of the cup on the C-arm monitor using a protractor, or the surgeon can estimate based on his or her experience. The C-arm is then tilted away from the operative side until it's in plane with the cup and a straight line is visualized at the cup's edge. The degree of the C-arm tilt is recorded and converted to cup anteversion using this chart. For a standard cup placement, 40 degrees and 20 degrees, a C-arm tilt of approximately 25 to 30 degrees is required. Once the cup is placed and position is verified, all traction is released from the femur. The leg is placed in 90 to 100 degrees of external rotation based on patient anatomy and soft tissue tensioning. The femoral releases are then performed. The first is the 6 o'clock release, which releases the tight pubofemoral ligament. This is carried down to the level of the lesser trochanter without getting into the iliopsoas tendon. The leg is then carefully lowered towards the floor and adducted until the proximal femur comes into view. A sharp wide homen is placed over the superior neck. This is the view that you should see prior to starting instrumenting the femur for the stem. The second release is the 12 o'clock release, which opens the superior capsule to allow the femur to be translated up and out of the wound. If done correctly, the femur can be translated several centimeters. If the femur does not move much, or you can't get a straight shot into the femur with the broaches, reset and do everything again and do the releases over. If you don't, you risk damaging the surrounding muscle, bone, or nerve. As you can see here, there's great exposure of the proximal femur without the use of a femoral hook. With knowledge of the surrounding anatomy and accurate retractor placement, this technique is powerful and reproducible. Once the final implants are in, stability testing is performed, the wound is irrigated, and the fascia is carefully closed. When done thoughtfully, the direct anterior approach is an elegant operation. These are the only retractors I use for this approach. Keep things simple. Your scrub tech and the rest of your surgical team will thank you. There are, however, challenges with the anterior approach. Most commonly, the lateral femoral cutaneous nerve can be injured, which presents as thigh numbness Studies show that the majority of thigh numbness improves by 2 years after surgery. You can also have various fractures, either of the greater trochanter, the femur, lower extremity if you're using a traction table, or you can come out of the bone with the broaches in very osteoporotic patients. Take the time preoperatively to counsel your patients on this risk. And remember, exposure during this operation is key. So let's talk about the outcomes. So this first randomized controlled trial, which was presented several years ago and won the prestigious John Charnley Award, looked at patients that underwent both the anterior and posterior approach from 2013 to 2016. It was done by only high volume surgeons who are very experienced with both techniques. It's very interesting to see how the anterior approach was better in virtually every category compared to the posterior approach. There was less time to discontinue the walker, 10 days versus 15 days, less time to get rid of all walking aids, such as a walker or a cane. The average number of steps was much higher at the first postoperative visit at 2 weeks. And the complication rate was equally as less, 8% versus 10%. There was, however, no difference in functional and patient-reported outcomes at 1 year. In another randomized trial, investigators noted that patients who had an anterior hip had better subjective pain scores in the first 4 physical therapy sessions when compared to a lateral approach hip replacement. If patients have less pain with physical therapy early on, they can ideally clear therapy faster and be discharged home sooner. Another randomized controlled trial found that patients with an anterior hip had on average a smaller incision, spent slightly more time in the operating room, but had a shorter length of stay in the hospital compared to posterior hip replacements. However, anterior hips had slightly higher blood loss, but this is not entirely significant as it doesn't translate to higher risk of blood transfusions. The same study also noted that anterior hip patients had less pain up to 72 hours postoperatively compared to posterior hip patients. Furthermore, anterior patients had better functional activity scores up to 3 months after surgery. Patient-reported outcome measures were not statistically significant between the 2 approaches, anterior and posterior. This randomized controlled trial, published in the Journal of Arthroplasty in 2019, showed that at 5 years after surgery, functional activity remained exactly the same, whether you had an anterior approach or a posterior approach. So, patients are doing better with the anterior approach in the early postoperative period. But how long does it take a surgeon to run a smooth anterior hip practice if you've never done it before? People will try to tell you the learning curve looks like this: smooth and gradual, like this. When in reality, it looks something like this. There's a slow beginning, then an acceleration in performance when things start clicking, and then a gradual plateau. The key question you have to be asking is, how long does it take to get from here to there? In a study published in February of 2021, so last year, the authors found that an experienced hip replacement surgeon who had never performed the anterior approach had an average operative time that decreased after the first 30 cases that they did and plateaued to about 100 cases. For a joint surgeon straight out of fellowship training, with training in the anterior approach, the time frame looks similar. In addition to improved operative times, the second 100 cases had a decreased hospital stay and nerve issues. More importantly, blood loss, the rate of discharge home, and readmission rates were not significant across the 200 cases. Outside of doing the cases, how should a new surgeon prepare for a transition to become an anterior hip surgeon? Neil Sheth from UPenn documented his personal experience and learning curve. In this paper, he goes over 9 key steps that occurred in the timeline for him to succeed. First, you have to know the anatomy. Then you got to observe an experienced surgeon who does the approach very regularly. You got to create your own step-by-step technique guide, and you have to attend a cadaver course, preferably one being taught by an experienced surgeon. then you need to be proctored, or someone needs to be looking over your shoulder while you do your first couple cases. In your first 30 cases, as I mentioned earlier, that's when most of the learning happens. So you need to take notes on things you could do better, things you can avoid, and things that went well. Then you need to be observed again by an experienced surgeon to tighten everything down and get things perfect. After case 60, that's pretty much when the results start being seen very positively. After Neil Schett's first 100 cases, he noticed that despite the procedure time increasing by 7 minutes on average, his hip patients were going home almost a day earlier than his posterior hip patients. In addition, his operative time greatly reduced after the first 30 cases. Okay. All right. So as mentioned earlier, the critical points in the learning curve tend to occur around case 30 and case 100. So overall, my take-home points are these. The anterior approach is a powerful tool for fellowship-trained hip surgeons in not only 2021, but going forward. The advantages include there's less surgical trauma. We go around the muscle, not through it, shorter hospital stay, and rapid earlier functional recovery up to 3 months after surgery. There's a faster discontinuation of a walker or a cane, and you have patients typically report less pain with physical therapy. The cons, however, there is occasional thigh numbness, some of which is permanent, some of which gets better over time. It doesn't affect your walking, but you do have numbness in the front pocket area. There's an increased risk of fracture. And, once you get past the learning curve, most of these risks go down dramatically. Thank you.
Thank you, Dr. Shah. Now we will turn our attention towards some of our viewers' questions. The first question that we have on the table is, can I still perform my normal activities after anterior approach? For example, can I ride a bike? Question mark.
Yeah, great question. So I would say for an anterior approach, another benefit would be you don't have any precautions after the surgery in terms of your movement. You can bend as much as you want, go up and down stairs right away. You're walking the same day. If you're using a posterior approach, you can't bend over and touch the ground or cross your legs for about 3 months. Those are the main disadvantages. But yes, with an anterior approach, you can bike ride, you can, go to the gym, do some light jogging right away.
Next question. How long does it take to recover from this surgery all total?
So what I always tell my patients is you're up and walking the same day. You can walk out of the hospital. You can go up to the second floor of your house and sleep in your own bed the same night. The full recovery is about 3 months, but you're feeling really good by 6 weeks.
Next question we have from a viewer is, what is the risk of a femur fracture with a patient with osteoporosis?
So in my experience, I haven't had any lower extremity fractures during surgery. Obviously, with more experienced surgeons, they'll see more. I would say the risk of fracture is less than 10% in patients with osteoporosis.
Okay. Next question. What should a patient know before deciding to have an anterior approach?
So that's a pretty broad question. I would phrase it in a couple ways. One is things to know before surgery and after surgery. You have to realize that having any major orthopedic surgery involves some pain, and you're not going to be in no pain, but the medications we give after surgery will help manage your pain. The pain is the worst in the first couple of days, and then it gets much better afterwards. The other thing that helps recovery in hip replacement patients is having a coach, and who that is a friend or a family member that can help take care of you in and around the time of the surgery. They're also responsible for taking you to your appointments and taking you to the hospital and home the day of the surgery.
Could you please review again what the most common complications are from an anterior approach?
So the major risk of anterior approach hip replacement is thigh numbness. Everyone has numbness around the scar. For some people, it's permanent. For others, it gets better with time. There's a chance of dislocation. The risk is very low. It's about 1 to 2% in the literature. The risk is actually less. It's a lower risk of dislocation if you go from the front than if you did from the back. And everyone has a small chance of a fracture, albeit very low.
Okay, and our last question that we have is, what attracted you to perform the anterior approach as opposed to the posterior approach?
I think that's a great question. That has multiple answers from my perspective. One, as times change and technology improves and surgical techniques improve and we get better understanding of how to manage patients' pain after surgery, outcomes from hip replacements are undeniably better now than they were 10, 15 years ago. And that can be, whether it's either anterior approach or posterior approach. Specifically with the anterior approach, like I mentioned earlier, there's less damage to the surrounding muscles. And patients, I've noticed, go home much faster and have far less pain than patients that have another approach. So those are the main reasons why I am a huge proponent of the anterior approach to hip replacement.
Good questions from the viewers. If you have further questions, please contact me, Janet Block. My email address will be displayed on the last slide. This concludes our lecture on anterior approach to hip surgery. Thank you again, Dr. Akash Shah, for spending time with us and providing both interesting and valuable information on the anterior approach to hip surgery. On behalf of the orthopedic department here at San Antonio Regional Hospital, we thank you for joining us in this community lecture series and have a good evening.